In the following video, we will evaluate a patient. We will discuss at the end of the video, when we're also measuring and using contrast and strain imaging, what the actual pathology is. All the time when we perform echocardiography, we start in a left lateral position. We use, of course, a cardiac transducer. This is a special transducer which also enables 3D echocardiography. We need ultrasound gel, and then we start at the parasternal long axis view. We already have a setting which I prefer, so the color is gold. Everywhere you have a possibility to change the color. So gold, it's more brownish, so it's better for my eye, and because of that I can see the image, especially in this very bright environment, better. So first of all, we start with this parasternal long axis view. We started at the clavicle, moved the transducer caudally, and here we have the interventricular septum, the right ventricle, the left ventricle, the mitral valve anterior, posterior mitral valve leaflet, here the aortic valve, the ascending aorta, sinotubular junction, and the aortic root. The left atrium, we can already differentiate, seems enlarged. Here we have the descending aorta, the pericardium. We do not have free fluid around the heart or in the lungs, as we can see now. So to continue, I always optimize my gain setting for my eye. So I want to see the structures of the heart optimally. You can also appreciate immediately that the heart has a pathology. Especially septum is severely thickened. So this, of course, can be hypertrophy, but we have to differentiate if there could be another cause, for example, arterial hypertension present. In this case, the interventricular septum easily exceeds 15 millimeters. You see here 2 centimeters. It must be around 20 millimeters. So it's definitely severely thickened. Therefore, it's unlikely that this is only due to hypertension. Now we have the parasternal view. We activate the color Doppler. We can also switch off variance so that you have the optimal Doppler setting you want. So the variance is this greenish color. You can leave it on or switch it off. You can also change the color Doppler setting, but for me this is perfectly fine. So I also save the loop. I always have 3 cycles. Here you can adapt the cycles, and you can also change the overall setting into soft or more harder, so that you see different echogenicities of the myocardium. You can also switch it off, then we have to have more gain. But overall for today, I want to continue for now with the soft setting, so to speak. Also, the time gain compensation is also already optimized, and when we have this standard view of the parasternal long axis, we can tilt the transducer downwards and see the RV inflow. So this is the right atrium, this is the right ventricle, this is the tricuspid valve, the anterior and the posterior leaflet, and he's not that easy to scan. So it's not the optimal image, but still we can appreciate the tricuspid valve. We then use color Doppler and continuous wave Doppler to see tricuspid regurgitation, which in this case we don't. Continuing with this parasternal view, we tilt the transducer upwards, and then we see also not very good in this case the pulmonic trunk, so the pulmonic valve and the RVOT. Focusing on the valves, we have to zoom in on the valves. First of the valves is, in this case, because I see it now, the mitral valve, I see that the mitral valve looks overall normal. There is atrial fibrillation present, most likely we do see it in the ECG we have, and also how the overall heart and contraction is moving. And we do see one interesting finding. So here this is the anterior mitral valve leaflet, and in the case of a thickened myocardium, we have to look for a SAM, as so-called systolic anterior motion of the mitral valve. And here we see it that the chordae tendineae are inserting at the papillary muscles, and you do see the LVOT. And when we activate color here, there is somewhat a turbulent flow. So we have to keep that in mind to later evaluate if there is relevant LVOT obstruction present. Then we have to also take a look at the aortic valve. In this case, it's harder to see, but we can appreciate that the aortic valve looks without severe pathology.